The current PI-RADS recommendations include rules for when to upgrade the final category assigned on prostate MRI. These rules have been controversial. In an article published this week in AJR, the author simulated what would have happened if the rules were disregarded, focusing on patient-level outcomes. If one were to biopsy all lesions with a PI-RADS score of at least 3, then disregarding the rules would have avoided 5.5 biopsies per missed significant cancer. If combining PI-RADS with PSA density, then disregarding the rules would avoid 1.9 biopsies per missed cancer. These numbers fall short of the author's assertion, based on prior literature, that at least 10 biopsies must be avoided per missed cancer to justify disregarding the rules. The authors also performed a decision curve analysis that assessed the net benefit in terms of the trade-off between biopsy avoidance and cancer detection, also finding that benefit is maximized by keeping the upgrading rules. I'm Andy Rosenkrantz, Editor-in-Chief of AJR, and I'm here today to discuss the article with its senior and corresponding author, Dr. Leonardo Bittencourt, Associate Professor of Radiology at Case Western Reserve and University Hospitals, where he serves as Vice Chair of Innovation in Radiology. Dr. Bittencourt, thanks for joining us.
Thank you, Dr. Rosenkrantz and the AJR for featuring our work and for having us here.
To start us off, can you tell us about your background in prostate MRI?
Sure. So I was trained in my native Brazil, and since I was out of my fellowship, I took an interest in prostate MRI, which was an emerging technology at the time, I would say 2006, 2007. And I had the chance to go abroad and to train with the likes of Dr. Behrens and Dr. Padani on their sites as the multi-parametric prostate MRI was being developed. And we happened to see the birth of PI-RADS as a classification system among the prostate community. And we built a prostate MRI program in Rio de Janeiro that became a significant program there. And we then started to perform fusion guided biopsies there and to publish in the field with other collaborators. And then at some point, we were invited to join the PI-RADS committee, where we serve until today. And now I joined, a few years ago, we joined my current institution, and we continue to work in promoting prostate MRI and disseminating the technique.
So in your view, why are the PI-RADS upgrading rules controversial?
That's actually a great question, because ultimately every rule in every RAD system should be a controversial rule because it is based off an expert opinion. But in the case of the upgrading rules in PI-RADS, it means that those are rules that we can apply that will bring a patient from a lower score, so maybe a patient that would not have to undergo a biopsy, to a higher score, meaning that the patient would have to undergo a biopsy. And by applying rules based off on parameters that are not considered the dominant parameters for that particular compartment. So many people would argue whether those rules would bring more accurate results or better results to the population, as opposed to just ignoring them and following a more strict classification.
So with that context, in the article, you say that the RADS Oversight Committee has recently weighed in on potential changes to the different RADS systems. Can you tell us about that?
Yes, so I think it was a great step taken by the RADS Oversight Committee, because like I said, since most of the RADS systems are based off on expert opinions, and everybody in a certain field think of themselves as an expert, right? So everybody would like to weigh in and bring their own content into any classification system. And we can jokingly say that if you look for any RADS system on PubMed, you're going to find a certain number of publications. But if you look for potential modifications to that RADS system, you're going to find many more publications, right? So the RADS Oversight Committee felt to help discipline any potential new changes or the maintenance of parameters to each RADS system by saying that anything now that you would like to change in any RADS system that will derive clinical impacts to the patients needs to be based off on experimental data and not anymore just expert opinion. So this is one of the things we're trying to do with this work here, is to provide some experimental input into why those rules are there in place in PI-RADS.
So that response will tie into my next question. A lot of prior research has evaluated these upgrading rules. What's different here in your study?
What's different in our study is that our study also answers another requirement by the RADS Oversight Committee, that any proposed change or, again, maintenance of PI-RADS or RADS criteria has to tie into outcomes felt by the whole population submitted to that particular system. So most of the studies that preceded ours, they were looking at upgrading criteria in rules or any other features of PI-RADS in respect to their diagnostic accuracy in between scores or overall accuracy. What we are doing here, which is innovative, is that we are incorporating that into the whole diagnostic pathways that cover the whole population.
Can you explain this threshold of 10 biopsies avoided per 1 cancer missed? It's really a key point of the article.
So I think the context here is that the paradigm today is not anymore that we have to diagnose every single prostate cancer in every single patient, but we need to optimize the detection of clinically significant cancer in the population. So there are definitions for what is a clinically significant cancer, as opposed to avoiding unnecessary biopsies in patients that wouldn't otherwise need them. And then to achieve the right balance as to how many cancers do we want to diagnose and afford to miss versus how many biopsies do we want to avoid and maximize its avoidance, it is something still within the expert opinion territory. And this number of 10 avoided biopsies allowing for 1 missed cancer was put out by the European Association of Urology and has been followed by some institutions. And we use this first number as a guidance, but this is an ever-evolving field. But what we demonstrated in our work was that if you would disregard the upgrading rules in any given pathway that we tested, those numbers would be suboptimal and substandard when compared to this proposed threshold of 10 avoided biopsies by 1 missed significant cancer.
In addition to looking at the effect of the upgrading rules, the article also looks at different approaches for selecting patients for biopsy, specifically whether to go just by PI-RADS or to also use PSA density. Any comment on this?
Sure. And this is also another emerging concept, which is broadly called the risk-based diagnostic pathways, which incorporate risk assessment parameters to PI-RADS categories in the hopes of better selecting patients that can forego a biopsy or the ones that will still need a biopsy. An example is that it is widely known that patients at intermediate to high clinical risk for prostate cancer that have a PI-RADS 1 or 2 score on their exams, hence a negative MRI, they are still at approximate 10 to 15 prevalence of clinically significant cancer on a biopsy. So if we were to biopsy all the patients with a negative MRI, then what would be the point of doing an MRI in the first place? So the risk-based pathway comes to try to answer this dilemma in better selecting the patients, even those with a negative MRI or with PI-RADS 3 scores that would have a higher risk and then would be referred for a biopsy, as opposed to ones that could be safely ignored for a biopsy.
I think the article, as much as making a point about PI-RADS, also makes a point about how we think about validating and testing standardized radiology reporting systems in general. Would you agree?
I do agree, and that speaks to what we were discussing in the beginning, that we should move more from expert opinions towards empirical evidence of the criteria that we are using to score our systems. So this is one of the exercises that now the PI-RADS Committee and the RADS Oversight Committee are trying to enforce.
So in the end, your study supports the upgrading rules. If it were up to you, what would you recommend next in terms of improving PI-RADS?
What I would recommend next is that everybody trying to improve PI-RADS, they should do their own empirical work too, because it is always welcome, the kind of evidence that can be weighed in to be incorporated. Any proposed changes, it would always be nice if they are based on empirical and experimental studies. But the PI-RADS Committee itself is now working in other interesting directions to bring to the discussion. One of them is to discuss the use of AI in the diagnosis of prostate cancer in biopsy-naive patients. Another conversation that is going to be started and restarted is to analyze the very diagnostic pathways that we were discussing. So what are the decision points that we need to consider in those risk-based diagnostic pathways? What needs to be included and changed? And those study designs, they will be very instrumental to inform those new changes to PI-RADS.
So one final question unrelated to the study. You're the vice chair of innovation in your department, and only a fraction of radiology departments have someone officially in that role. Can you tell us more about the position and what you do in it?
Sure. And that's my favorite question to answer. So as I told in the beginning, I was recruited to join my current institution here from my native Brazil. And I was recruited straight to become vice chair of innovation here. And it was a position that was created when I joined the institution. So it didn't come with any formal content or any formal immediate expectations. It was a work in progress from every side. But and then also I interacted a lot in the beginning with people from neighboring areas. So people from research, people from education, people from IT. And it is hard to understand where is it that innovation differentiates itself from pure research or from pure IT or from pure education, much more so that it overlaps with all of them. And I think that that's when I found the perfect area for me to operate in innovation. Innovation is the kind of glue that brings all those academic initiatives and business initiatives from a department to fruition to solve a real problem at scale in a way that is better, that is cheaper, that is easier, that is more effective, and can materialize into something that brings value to the department and to the patients. So one of the things that I currently dedicate the most in my activities as Vice Chair of Innovation is that we created a program called Radically that is aimed toward industry academic collaborations in the field of AI in radiology. So what we do is that we interact with companies and startups that have emerging AI applications and that they want to improve their products, they want to get expert opinions, they want to validate products, they want to to get their products to the regulatory pathways. And by doing so, we expose all of our faculty, our residents and trainees to interesting initiatives in AI that would be otherwise harder for them to interact with only with the academic and pure scientific way.
Dr. Bittencourt, thanks for joining us.
Thank you so much, Dr. Rosenkrantz and the AJR.